Hello everyone, my name is Jake Timothy, I'm a spinal neurosurgeon from Leeds, and welcome to this X360 webinar session. Some people have seen the other X360 sessions, and people have asked me, well, what does X360 mean? Well, it's a concept. It's a concept of doing 3 separate procedures in the same lateral position. So you can do your XLIF, which a lot of people know already, but also you can do an XALIF at the L5-S1 level in the same position. And in addition, you can put your screws in a lateral position, which Nuvés have called X fixation. Now, there are several advantages of adopting this concept, such as number 1, for the patient, there's less anesthetic time. Number 2, for the surgeon, you don't have to change the position of the patient, which means it's faster turnaround in theatre, so everyone benefits. It's my great pleasure and a real treat to introduce Pedro Berjano, who is a well-known, respected international surgeon who's pioneered these minimally invasive techniques. Now, Pedro will tell us about his journey from the open techniques to how he's adopted them in his practice, the pitfalls, and how the outcome of his patients have improved by doing these excellent procedures. And it is a real treat because there's not only is he a master of surgery, but also some really great videos. And what we've seen from adopting these techniques, just if we talk about XLIF over the years, is we now have expanded them to do far more complex surgery, such as vertebrectomies, and again, different pathologies, not just scoliosis, but also tumours. So without further ado, I'd like to introduce Pedro Berjano. Please enjoy.
Hello, my name is Pedro Berjano, and I'm an orthopedic spine surgeon working in Milan, Italy, in Istituto Ortopedico Galeazzi. And here you can see some of the flashes of my career. My clinical and research interest is complex spine surgery, adult deformity, MIS techniques in complex spine, and adult revision. And today I'm going to talk to you about something which is like a journey, and it's my personal journey towards lateral access surgery, why it has been so useful, so important, and so successful in my clinical practice. And doing this, I will discuss also not only on what brought me or how was the process to incorporate lateral approach surgery, but also what is bringing particular value to my practice from XLIF, and also in what cases I have learned that XLIF brings new opportunities, so that I can do things that before I could hardly do with the previous techniques. So I will start with it's a little bit emotional, because it's like looking backwards to your life, and you see how much effort and how much struggle we all have to face to be where we are now. And this journey started when I was still a resident in the 90s. There was, as many of you will remember, there was a worldwide move and a worldwide interest in spine surgery toward endoscopic fusion of the spine. It was done mostly thoracoscopically and laparoscopically. And I had the chance to participate in a very interesting and multi-center collective effort to achieve this success. And I will show you some of my experience in those years, like this case of a post-traumatic kyphosis in the thoracic spine over a Scheuermann's disease, and how we perform thoracoscopic release and posterior fusion to get a very nice outcome. In that period, the standard for this was open thoracotomy and posterior surgery. Or this case, it was the years of the development of the internal fixator for thoracolumbar fractures. But as many of you know, in cases like this with huge comminution, even a very nice restoration of the height or of the alignment of the spine could fail over time. So in this specific case, after checking radiologically the outcome post-surgically, we usually performed an anterior fusion. And this was my case, and this was 1996, I believe, or 1998. And this was a very tiny approach for the time. I remember that in that time the standard thoraco-frenulombotomy was the standard approach for doing this. And here you can see some pictures of what we were able to achieve to place an autologous iliac crest graft to achieve this kind of fusion. Or what solutions we were looking for in the lumbosacral area. You can see this case of a laparoscopic technique. This is the OR setting. The arrow is over a very young version of me with one of my mentors watching the screen, and with the general surgeon looking at the whole scene because he was standing by me just in case. You can see here the approach and the result. And it's funny because it was minimally invasive, but if you see this patient after surgery, you have also the impression that he had a very bad encounter in a dark alley somewhere. So it was minimally invasive, but it was not the standard I was aiming to. And another example, this is what we called mini ALIF L45, and as you can see, it was an oblique approach along the oblique muscles. This was the surgical pathway, and interestingly, this is what we call today OLIF. This is a case of 1998. And here you can see the clinical pictures. At that time, we didn't have specific implants for this kind of anterior oblique corridor, and so I used two threaded cages that the eldest of you will remember, and that were not the perfect stability, not the perfect fusion device. And I was always concerned about the use and the interpretation of this oblique anatomy. When you go anterior or when you go lateral, you know exactly how is the placement and how is the performance of your implant. When you have an oblique approach, you are no longer so sure of what you are doing. You cannot be sure that you are too posterior or that you are even creating some scoliosis, like in this case that has some coronal misalignment post-surgically, certainly induced by the destruction at one side. This is what we now call OLIF. That's what I called in that time mini ALIF. Very interesting is that in those years I had my first experience on a transpsoas approach. In this picture you can see a very young version of my friend Daniel Rosenthal, who has been a very clever and very brilliant innovator. He is working with his octopus assistants. He was very fond of them because they were not asking for a raise in salary and they didn't give opinion, as he used to say. And here you can see the tiny implant he is using through a transpsoas approach. Again, it was a period where the drive was there, where the interest was there, but we didn't have the specific tools, the specific methods to do that. So my impression is that all of these cases of anterior surgery were like fiddling, where you needed to be a very good and a very virtuous surgeon, and it was like walking on the tightrope, always doing things that are on the limit of your ability to manipulate the tissue and to manipulate the implant. So for that reason, at the end, about 2003, I gave up and I decided to stop doing everyday things that are too challenging and where you take some additional risk. And I focus mostly in open procedures. And why open procedures? Because for doing minimally invasive. We didn't have specific instruments. We didn't have specific implants. Most approaches were oblique, and I didn't feel comfortable with that need of virtuosism in every single surgery. What happened in 2008 is that I made the acquaintance of XLIF. And when I first saw the model having that retractor, and when someone gave me one explanation, I understood that it was it. XLIF provided one opportunity of using orthogonal geometry, transverse or sagittal, specific implants, side to side, a very big implant, a complete instrument set, so you didn't have to adapt some instruments from here or there. You didn't have to go, as I used to do before that, to the smith to ask them to manufacture for you something that was looking like a surgical instrument, but was not. And finally, it was a safe approach with neuromapping, with neuromonitoring. So, in other words, in my opinion, and at first sight, I realized that XLIF was opening the way to safe and reproducible anterior MIS. So we're there. I started making my experiences in XLIF, and now I can look back to it after probably 12 years of practicing, or 13 years of practicing, of using XLIF every week in my practice. And I will give you a summary of what clinical environments I have been applying XLIF with success. So here you can see one of my first patients. He was an assistant of a fish shop, of a fish market, and he was lifting heavy weights. He was like 30 years old, and he felt really disabled about chronic back pain. The only finding in MRI was a black disc. The X-ray was normal, but this guy didn't have any psychological problems. He didn't have any cognitive problems. He didn't have any drug abuse. He was a strong worker, and he was one of the cases where a black disc does mean something you can relieve with surgery. It is not the case for every black disc, but in some cases a black disc is the problem and surgery is the solution, as it was. And in this case I perform an XLIF approach. You can see that it's a young approach with a cage placed a little bit obliquely, because I tried to go away from the plexus at the beginning. I went far in front and then aimed posteriorly, so still not a very good orthogonal approach. I use percutaneous pedicle screws only on one side, and here you can see a dramatic drop of the disability score and of the pain score after just 1 month. At 3 months the change was persisting, and at 12 months the patient was virtually perfect, with no symptoms, with no disability, and back to work completely very happy. What about this use of unilateral pedicle screws with XLIF, which is something which is not so standard? And here is one slide that I love to show, because it gives you some idea of why does this work. In this horizontal white line you have the range of motion of an intact segment of motion in the spine, and you can see on the right that when you use 2 pedicle screws in one cage, you reduce dramatically the range of motion. In the red bar you can see the TLIF behavior when you use XLIF cages with 2 pedicle screws. As you can see here, you reduce even more the range of motion of the segment. So this gives a safe environment for fusion. What happens when you go to one side pedicle screws? Here you can see XLIF, due to the large cage which goes coast to coast, that covers most of the end plate, still is keeping much of the mechanical performance and still is overperforming the bilateral pedicle screws with a banana cage. Conversely, the TLIF banana cage with unilateral pedicle screws reduces significantly the stability and poses some challenge to fusion. That's the reason why when I use a good large cage with XLIF, I trust unilateral pedicle screws for one or sometimes for two segments of motion. Here is a second patient, and as you can see, I remember very well these patients because it's about people's lives, and it's about people who had a bad life and who went to normal life again thanks to technology and thanks to our commitment. And here you can see this lady had a normal MRI, she had a normal X-ray, and she was a teacher and she was complaining from very bad back pain. And you know, when a teacher who is in her 40s or late 40s is complaining from back pain, some people tend to think that it's psychological, that they are no longer compliant with their job. But look at this. In the flexion X-rays, you can see the anterior collapse in L4-5 and in the anterior displacement. So I believed that this was the source of pain, and I treated this patient, this lady, with XLIF bilateral percutaneous screws because it was highly unstable and I wanted to provide the maximum possible stability. And here you can see again on this table how her ODI score dropped from 60 preoperatively to 12 at 3 months, to 8 at 6 months, and then it went on improving. I'm following up this patient now for 10 years and she is still working, still taking care of her spine by swimming every week, and she's very happy of her results. And I'm very happy of helping people to improve their lives. So what are my top indications for XLIF in my practice? What are the scenarios where I see the most of the benefit? I think that I would say that the number one is degenerative spondylolisthesis with stenosis. When these patients do need a fusion, I think that XLIF, indirect decompression, percutaneous posterior fixation is the best solution I can provide to them. Adult deformity is, of course, a very interesting field of application of XLIF, not only for corneal, but now, more recently, also for sagittal deformity. My third best indication is giant calcified thoracic disc. I think that thanks to the instruments and to the retractors and to the philosophy of the XLIF approach, I can do a safe anterior decompression and fusion, and I can provide better value to my patients than I did before. Infection is a natural indication for anterior approaches for evacuation, debridement of the collection and reconstruction, and revision surgery, where you want a new pathway that has not been touched, which is free from scar tissue, and you want to provide excellent stability, excellent surface for the fusion to enhance the chance of getting a good union. So let's see again some new people's lives. And this 70-something-year-old gentleman who loved still walking in the mountains, who loved still taking care of his garden, but who was disabled by back pain and by neurogenic claudication due to this L4-5 spondylolisthesis. And here you can see the malstenosis, you can see the psoas anatomy, and what I did, I performed in this case a one-level XLIF interbody fusion. I did not perform any direct decompression, and I performed a unilateral pedicle screw fixation. This was also a case of my early years with XLIF. Now we routinely do single position percutaneous fixation, and in virtually every case I prefer doing it bilaterally, just for bigger safety. But I have to confess that in the more than 50 cases of unilateral pedicle screw fixation with XLIF cages, we didn't have a higher chance of non-union than with bilateral. And here's some of the difference. This is the patient next day after surgery. The patient is moving, he is standing up. You need to have a good analgesia postoperatively to get this kind of mobilization. But you can see here, He wants to cheer. He's happy of being able to move. He has he has the temper to joke with his situation. Here you can see the test we usually perform to check that they don't have any loss of flexion power in the hip. Another case, this lady that had a previous fusion L4 to S1 due to stenosis, but who had also degenerative scoliosis, and over time she had a bad evolution with junctional disease, and the discs above became symptomatic. She had very severe pain above the previous fusion, and I remember this patient because in the first surgery she was not a fit woman. She was very weak, and she had a lot of problems after this 2-level fixation and decompression. And I performed in this case a 3-level anterior fusion with an XLIF approach. Probably now I would not have left alone this case with only anterior fixation, but in that case I did, and I have to tell you that the clinical result has been excellent. This is the patient in the first postoperative day. She's able to move and to go back to bed with virtually no assistance, only for having their all this intravenous fluid collection, and she was able to move. I have been following this patient now for 9 years, and she had the chance to fall, to break her hip, to have dislocations of the hip replacement, but the only thing she says that is working perfectly is the spine. Just to give you an idea of what good carpentry and good support in the anterior column can do for our patients. Another case of deformity. This is again a 70-year-old woman. She had unbearable pain for 2 years. She was sleeping out of bed for 1.5 years when I met her. She didn't have any neurological symptoms, and we discovered this scoliosis, which was very stiff, very sharp in the thoracic spine. And in that period where we were discovering collectively how to use these powerful techniques for adult scoliosis, and I'm very proud of having participated with my partner Claudio Lamartina to the definition of these categories of scoliosis, and that has given us a lot of help to decide how to deal with scoliosis using minimally invasive techniques. So in this case, where we had an extensive degenerative condition that was affecting the apical and the non-apical parts of the curve, we did a long fusion with 6 discs included in the fusion. You can see here these XLIF approaches, then percutaneous pedicle screw fixation with some reduction at the apex of the convexity, some posterior translation of the pedicles, like a reduction of spondylolisthesis just to provide the rotation, and some pushing of the apex in the convexity for the same reason. And doing this, you can see that you can virtually complete the rotation of the apex of the curve, and you can provide an excellent realignment of the spine. This is the postoperative clinical and radiological result, and over time the performance of this procedure. I was talking before about a giant thoracic disc, and I think that here having the right instruments and having the right retractor has made the biggest difference in my experience treating this very difficult and very challenging condition. Here you can see the CT scan of a lady. She was a 30-year-old lady with a giant thoracic disc who had some numbness in the leg and had some discomfort in one leg when she first met a surgeon who performed this decompression, which was incomplete. Here, what you can see here is the postoperative MRI and the postoperative CT scan. Unfortunately, after this surgery, this patient became more paraplegic. here you can see this lady, she was just married and she was virtually unable to stand alone without assistance. She has a very severe ataxia and she had a very severe loss of muscle power. So here you can see how some of the intraoperative images, how we were delivering the fragment, the corticalized bone, compressing the spinal cord. And here you can see the CT scan of the post-op images with the very nice decompression, the rib graft placed vertically, the cage, and the posterior fixation with pedicle screws. Even the pedicle was removed for safety to be able to decompress the spine. And here you can see the patient 6 months after surgery, how she has recovered the stance, the ability to walk, and even to run, which you know is much more difficult for patients with myelopathy due to a thoracic disc or to a cervical disc disease. Regarding infection, I would like to show you this case. This is a case not of non-active infection. This is a case of tuberculosis who underwent pharmacological treatment which resolved the infection, but she had still a very bad compression of the spinal cord and a very bad alignment. And I found this patient in the rehabilitation ward. And so I proposed this patient a reconstructive procedure. First, for safety, we took samples and we drained the collection, which was sterile, and then we did the compression with an anterior approach. You can see the patient was so tiny that a 16 millimeter XLIF cage made the work of replacing one vertebral body. And then we did an open posterior reconstruction to complete the alignment that has been preserved very nicely over time. These are cases where XLIF is a very good indication, but I can think about even more. There are some cases where XLIF brings new opportunities. So I mean with new opportunities, things that probably I would not be able to achieve without XLIF or not with the same safety. And this, I think, is regarding mostly corpectomy and the possibility to reduce the use of pedicle subtraction osteotomy thanks to the use of anterior column realignment. Just two examples. This is an 87-year-old lady who had a 2-level vertebral compression fracture that evolved into osteonecrosis. And this lady, who was before this fracture walking in a walker, after this fracture could not be sitting, could not be standing, could not work with the help of a walking aid due to excruciating pain in the back. So after a lot of thinking and discussion with her family, with her doctor, we decided that probably the only option, given that she did I want just to show you how is the operating field of this kind of surgery. Through this operating field you can resect 1 or 2 vertebral bodies, you can replace them, and you can do a very nice reconstruction. And this is what we did in this case. And here's the reconstruction we achieved. Of course, we were not able to restore the global sagittal alignment to normal, which wasn't before this fracture, but we were able to completely restore the normal sagittal alignment of the affected segments. And thanks to this, the patient was back to sitting, was back to standing, was back to walk with some aid of a wheel walker. And he has been followed up now for 3 years with a very satisfactory result. Of course, she has some lower back pain, but she is happy with her current condition after this surgery. And just to end with these cases, one case of a 76-year-old woman with a very severe condition, degenerative sagittal imbalance, is in spite of some minor surgeries in her spine. In this case, where of course the patient needs extensive posterior fixation, she needs extensive correction of the lumbar hypolordosis, what is the place that I think that is revolutionary for XLIF? To reduce the need of PSO. The same realignment with or without PSO means much less risk for the patient's life. And here you can see the small approach and the virtually bloodless approach that you can do for dissecting one disc bilaterally, for resecting the disc, and for releasing the anterior column. Here you can see the cove retractor and the anterior retractor placed to protect the great vessels in front of the disc to be released. Here you can see the discectomy and the release unilateral and contralaterally, and here you can see the moment where we perform the anterior release of the anterior ligament in order to make flexible the spine and to be able to do the correction. Here you can see this is the moment where we lost the resistance of the anterior ligament, we control it on X-ray, and after that we do our reconstruction with the XLIF cage. Nowadays we have even the advantage of using a expandable lordotic cage that makes things much easier. You place a closed cage which is 10 degrees and then you can open it to as much as 35 degrees to provide much more control and much more progressive and tailored correction of the alignment. Here you can see the outcome of this patient after this long posterior surgery, but which was able to avoid any PSO, any 3-column osteotomy. And here you can see the different aspect of the patient before and after the surgery. So what are my takeaways of this experience, of this more than 10-year experience using XLIF and more than 20 years trying to do a better surgery with MIS? My takeaways are that XLIF is, after many huge amount of international publications, is proven and has predictable outcomes, thanks to a very specific technique and a very good teaching pathway and a tailor-made set of instruments, of implants. It's a reproducible technique. You go into the OR knowing that you will achieve the goal you have established for the patient. Mechanically, it provides a great support. I think it's the technique that provides the best support to the anterior column, and it translates into very good fusion rates as we published some years ago. And finally, the versatility. As I have shown in this presentation, XLIF is a wide spectrum MIS fusion technique that you can apply to a huge spectrum of different patients.
Well, I'd like to thank Pedro for that fantastic webinar and all those pearls of wisdom. It's really has been a journey for many surgeons who have adopted these techniques early on, and the XLIF, from this new concept over 10 years ago, has now been used by surgeons across the world. It's also not just anecdotal evidence, it's really good scientific evidence that these techniques have helped our patients and the outcomes of our patients dramatically compared to the open posterior techniques. Nuvasive is a very progressive company. They've innovated in spine, not only in their retractors, but their neuromonitoring, but also their concepts. And this is another concept that we should try to learn, adopt, if it helps and makes sense in our practice. So there are materials out there which will help you if you are interested in the X360 concept. The next webinar, which will be broadcast, will be about X fixation, and that's for me, a very difficult concept to put screws in a lateral position. And that's going to be hosted by Gergely Borden, who's very experienced in this technique, and he's going to hopefully excite us and inspire us to adopt these techniques. So again, I'd like to thank Nuvasiv, I'd like to thank Pedro, and I hope you've enjoyed this session.